Thank you so much. So I'll be talking primarily about subthreshold laser therapy guidelines for retinal diseases on behalf of our society. This is These are my financial disclosure, and to specifically mention about ODOS, which makes the never last laser, and I'm a consultant for ODOS. This was our guidelines, which were published recently in Journal I. And I thank all the co-authors and the committee for working on this project. Before we really get on to the guidelines, why do we need guidelines for subthreshold laser? Because we know that subthreshold laser therapy has been utilized in clinical practice for more than 3 decades. However, there are various randomized as well as real-life studies available evaluating the efficacy and the safety of subthreshold laser in various retinal diseases. Despite this, we really do not have any standard protocol for the subthreshold laser, and we all work with different devices, and this is what actually being defined by the industry or particular device that, this is the setting for my machine. So we, on the behalf of society, we really wanted to put this together and come up with a standard guidelines. So the aim of this study was to establish consensus guidelines for subthreshold laser in retinal diseases, and we picked diabetic macular edema and central serous as our target diseases because these are two of the most common indications for subthreshold laser. We had 12 experts in the group. We created 43 questions. In the first round, we sent out these questions in the mask manner. We got the responses and we kept the masking on till we met for 2 virtual meetings where we went through the questions and we discussed the areas of no consensus and how do we actually solve those conflicts. The very specific goal of this project was that the guidelines should be independent of any specific laser device. So let's get on to the guidelines for diabetic macular edema. So the SOLS Society supports the use of subthreshold laser for both central involving as well as non-central involving diabetic macular edema in conjunction with or without anti-VEGF therapy. We recommend 5% duty cycle with 200 millisecond pulse duration with 150 to 200 micron spot size without any spacing between the burns, as Lite was mentioning, by using multi-spot laser device. We recommend doing the titration with the subthreshold laser and cutting it to 50% of the threshold power. We do not differentiate between the edematous or the non-edematous area, and we do not mandate any focal treatment for microaneurysms. SOLS Society does support the transfoveal treatment because we believe it is safer to do with using subthreshold laser. However, we had to just reconfirm the subthreshold laser settings before you perform a transfoveal laser treatment. We do not recommend any specific structural imaging studies to evaluate the laser spots. However, if the physician wants to do an autofluorescence on OCT, that can be performed to evaluate their patients carefully. We recommend follow-up evaluation at 6 to 8 weeks after the subthreshold laser. However, repeat subthreshold laser is suggested after 2 to 3 months of initial application in case of poor response. As you saw that I kept talking about subthreshold laser settings, we do not recommend any specific management of the diabetic macular edema, but these are specific guidelines for laser therapy. That means that the physicians should decide any adjunctive therapy which they would like to offer their patients, like Lite just mentioned about, doing with initial anti-VEGF therapy or steroids, and then adding subthreshold laser. So we do not recommend management of diabetic macular edema, but we are recommending laser settings for subthreshold laser for diabetic macular edema. Moving on to central serous chorioretinopathy, we recommend subthreshold laser for both acute as well as chronic subtypes. For acute laser, as the subthreshold laser is very safe, we can offer this treatment at 1 month if there is no self-resolution, in contrary to the conventional laser, where we believe in waiting for almost 3 to 4 months or longer. For chronic central serous chorioretinopathy, we recommend subthreshold laser as the first line, as well as in combination with other treatment options. We should use 5% duty cycle with 200 millisecond pulse duration with 100 to 200 micron size, and the similar way of doing a titration with subthreshold laser and cutting it to 50%. Settings are same for both acute as well as chronic central serous with no spacing between the spots. And transfoveal laser application is again safe in this disease with reconfirmation of subthreshold settings. Acute CSC, we recommend focal leak as well as into the adjacent area. For chronic central serous, we recommend focal as well as diffuse hyperfluorescence on fluorescein angiography should be treated with a confluent buns. Autofluorescence and OCT could be carefully evaluated during follow-up, but there is no specific reason to look for any laser-induced damage because we know that subthreshold laser does not lead to any structural damage with 5% duty cycle. We recommend evaluation at 6 to 8 weeks, but in case of poor response or persistence, a repeat treatment can be performed with the same settings in conjunction with some adjuvant treatment per physician discretion. This is just a table comparing both diabetic macular edema and central serous settings. They are almost pretty similar except the laser spot size. So with this, I would like to conclude that these consensus guidelines do not suggest management of these diseases, but suggest laser application guidelines using different subthreshold laser delivery systems. The goal is to establish standard subthreshold laser application in clinical practice. And as a society, we aim to establish level 1 evidence by performing clinical trials with using standard settings. And this is the publication which came in Journal I. I would recommend you all to go through this. And as a society, we would love to hear more details and any feedback on your experience. Thank you so much.
Thanks, Jay. That was wonderful. Any of the panelists have any questions for Jay? Go ahead.
Yeah, Jay, no, great presentation. My question, I know you had mentioned in your slide, one of your last slides about follow-up and when to see these patients back. As far as retreatment goes, do you have kind of guidelines on when you retreat, what your kind of criteria are to say for a patient, like for example, for CSR, let's say, and this happens to all of us, we treat these patients and they're getting better. You might see them 2 months later, 3, 4 months later, they're getting better. But at what point do you kind of say, well, it's good, but not good enough, let me treat again?
If this is a very tricky question, and the CSCR is a tricky disease. So I would say that, we have done a couple of research work on this, and we define the treatment response as, a complete response or incomplete response and no response. If I'm seeing a complete response, that's great. But if we see an incomplete response, and if it is no response, then you know that you have to redo it. But if I see an incomplete response, if I'm seeing the patient at 2 months, then I would just ask him to come back in maybe 4 to 6 weeks, or by 2 months, I would like to treat it, because personally, I feel that leaving that shallow fluid, particularly at the foveal area, we are constantly letting the photoreceptors die, and the overall recovery is not great. So my threshold for the repeat laser is around 6 to 8 weeks, particularly with the subthreshold laser. I'm sure all of us have used this. Particularly with the subthreshold laser, our threshold of doing the retreatment is very low in comparison to the PDT, because you are always afraid of repeating PDT just with the fear of RP atrophy. But with subthreshold laser, we can safely repeat it. Lita, you have a lot of experience with this. Why don't we hear from you as well?
No, I have to agree with you. I mean, with subthreshold laser, really, there's a little risk of retreating. So I used to do 6 to 8 weeks, but usually by 1 month, If there's still some residual fluid and the patient is insistent, I will probably offer retreatment at that point. Supriya,
Oh,
do you want to ask your question?
Wonderful presentation, Dr. Jay, and wonderful paper. I wanted to ask, do you have some general guidelines on when should the micropulse laser be done in diabetic macular edema? Like any thickness, like is it the same as for focal laser? We want the thickness to come down by treating with anti-VEGF and, then go ahead.
I would let Lite answer this question because he started in the very beginning about DME. Lite, do you want to take it?
Sure. So since I have access to the micropulse laser, I just use it in lieu of the normal laser. So usually my treatment algorithm is get the maximum response after the anti-VEGF, be that 5, 6, 7 injections, whatever, and then do the laser as adjunctive therapy. There are papers, like I mentioned in my talk, that if the thickness, the CMT is greater than 400, the response is probably not that great. And it works better if the CMT is less than 400.
Okay, thank you. Yeah, similar to focal like.
Yeah. There was a question. Well, they took out the questions, but maybe
I answered the question. Sorry. Yeah,
no, it was about the duty. Oh, you answered it already. Okay. Okay.
yeah, it was about whether to use 10% or 15%. Then I answered is for 5%. Yeah.
Okay.
Yeah, but Supriya, just to add a little bit more to your questions, that definitely there is a group of experienced people who are using subthreshold laser, believe that the edema does not define at all the laser power or the time, because here the laser is coming onto the RPE. But as a SOLS society, what Lite described, that we came up with some numbers, because we cannot, like, you can see like edema of 1200 microns. So we know that we need to treat these patients first with anti-VEGF and then jump onto the laser. So trying to find some midway, there is no perfect answer to this. Great. Any other questions?